introducing this time. Joel Teles, I met already 12 years ago. We started a nice journey together when there was still only the performance line at the at the TRI system. And we started the journey to to educate dentists to full arch treatments in a very analog way. And your first presentation here in this webinar series is about analog to fully digital workflows in full arch treatments. And you will share even with us up to 10-year follow-ups on TRI implants where we still used abutments. And then you go with us into the journey of the matrix implant and a full arch treatment, abutment-free treatment system, and fully digitally.
So it's not. I was saying it's nice to be back to this series of webinars. We've done a bunch over the past decade, and this is a topic that I am quite interested in. My main focus in my practice is about full arch restorations. So this is something that I always love to speak about. And I will try to make this a journey from the fully analog times with TRI more than 10 years ago to this moment in time and what has evolved since. So I've been part of this TRI project from the early stage when it was open to the first clinicians, and I am lucky to be part of it. And so I will try to make a journey. Olga, this is me and you, way younger, a few years back. Olga, are you listening to me? Is the sound okay? Olga, is the sound okay?
Yes, everything is.
Olga?
Yeah, I was already.
Okay.
Yeah, yeah.
Okay.
Everybody is listening.
Okay.
Don't change anything now.
Okay.
Now you change.
Okay.
Please
Now
keep
I'm
going.
back. I'm back.
Thank you.
I'm back. So, and our journey from the early times was my main goal with these full arch courses that we created is to make people understand, and this is 2015, 2016, that no matter the beginning situation, we should always have a plan to make our patients leave the office with a set of fixed teeth. I never enjoyed the situation where the patient would come for the implants and then with the removable on top of them and only afterwards go for the provisional restorations fixed and then for the final. Always in my cases, I always do immediate loading. That's standard for me for more than a decade now. And this was our journey in the beginning, me and August speaking about these techniques and lecturing about it and make people understand about all these basal anchorage techniques. From palatal approach to shelf technique, M technique, a lot of different basal anchorage that you can find to make your patients, even in tricky situations such as this with 1 millimeter cortical, to leave the office with a set of fixed restorations. And this case is now turning 10 this summer. And it was one of the first cases I presented for TRI. And this was back in the time where everything was fully analog. So this patient came to me from the UK. She had a car accident when she was really young. And so she broke a jaw and she lost all her teeth. And back in the UK, the proposal she was having, and keep repeating, was that she needed zygoma. There was no way of doing this surgery with standard implants. So somebody referenced that to me, and I had her for a week. And during that time, and this is the assess of the initial situation, and you can see there on the right side on the CT exams that there's very shallow premaxilla area. And as soon as you go a little bit on the posterior parts, there's no bone whatsoever. Nevertheless, my proposal was to give a fixed teeth in the same day. And so what I said to her is that, okay, we're going to try a combination of techniques here that will allow us to get a very good basal anchorage and go around these very tricky situations without bone grafts, without the morbidity and the cost associated with bone grafts, and without zygomas, because I don't like zygomas all that much. I always prefer to avoid them if possible. They're like a less resource together with individual implants. Periosteal implants. So for me, whenever possible, I try to go with standard implants. That's exactly what we did here. So we did a combination of two techniques. It's an all-on-4, but with a shelf technique, described by Jensen in 2010, and with an extreme palatal approach on all the implants. The very cruel thing about this is that when you're dealing with these types of techniques, you need to be pretty accurate, because you can see this is a very slim part of bone and it's all cortical. So you gain torque like crazy. And you need to be really careful when placing the implant, and you need to select the correct shape, macrogeometry of your implant. Because if you go with the implant with very wide threads, you will cut through this cortical that you want to preserve. And you can see there on the implant of the 11th position, you can see there even the bone cracking due to the high torque of that implant going inside. And it's very important that you don't rupture this architecture, because this is what will serve you as a bulletproof over this period of time, over the healing time. So in this case, as she came from the UK and we only had her for a week, we did a provisional using her restoration. So we pick up these prosthetics that she was wearing for the longest time, and we picked it up. Pretty easy, pretty analog, basic stuff. And this is the post-panoramic X-ray immediately after the surgery, where you can see that we aimed for the piriform rims and for the nasal corticals to get that primal stability, that anchorage, basal anchorage, to allow us to do the immediate fixation of the teeth. And in the lower jaw, we did a standard all-on-4 procedure. Now, this is the post-op CBCT, and this is quite cruel, because when you look at the image on the left side, you can see that all the implant threads are exposed, are outside bone, and only that very thin cortical is protecting these implants. And I remember, Olga, and you remember for sure, that when I first started showing this case, people were scared. People were unsure if something like this would work. Even though this is very old technique described by Torsten Madsen in 1999. So this is nothing new, but people were still pretty scared when we were showing these cases worldwide, me and you. This patient went back to the UK, and for 18 months, we didn't heard nothing from her again. And she was trying to come back for the final restorations, but she was low on budget. And so she had to postpone for 18 months. And after 18 months, she came back. I unscrewed the provisional restorations. This was the situation. And on the image on the left side, you can see how thick that portion of tissue on the buccal side is. So if I showed you only this picture, you would have no concern whatsoever of what's going underneath, even though I just showed you. And this is 18 months CT scan images for each implant in each position. You can see that there's no bone whatsoever on the palatal part. That's why it's an extreme palatal approach. But you can also see that all the buccal wall is well preserved. And remember, if it was less than 1 millimeter, you wouldn't see it in the CT scan. So it means that it's higher than 1 millimeter now, that cortical. You can kind of see that it, even on the image on the right side of your screen, it kind of adapts to the implant, because once it goes in, as it is passive aggressive, it will stretch the cortical, and you will have control of the torque going in. You be careful not to exceed it, and the bone will adapt. So we went for the final restorations, metal acrylics, fully analog procedure, exactly as she wanted and according to her budget. And she was very happy with the result. That's her smiling afterwards. From this situation to that situation, need a single surgery and a very easy protocol, even though fully analog. Now, 7 years in time, she came back to me 7 years after the procedures, and we unscrewed the restorations. This was a tissue situation. You can see now that in the upper jaw, it's much more flatter due to the basis of the prosthetics, but extremely healthy tissue. This was the 7-year follow-up X-ray, everything looking pristine. And now the last control was a little bit over 9 years of follow-up. And you can see on the CT scan, you can see here if you look on the image on the upper right, you can see how everything is well preserved. You can see the full buccal cortical. You can see the anchorage on the piriform rim. Then you can see that golden triangle being used, all the buccal wall well preserved on this 11 position implant. On the 21, the same thing. You can see it going right up to the nasal cortical there, getting that anchorage. And again, on the piriform rim, on that golden triangle with both corticals helping you, really high torques. And after 9 years, this is the situation. So again, when you look, you can see that all the threads on the palatal side are still exposed. But 9 years down the road, this is working properly with a very easy surgery, with very low morbidity and very low costs and very low maintenance as well. So this is what drives me in these types of cases when we're dealing with really resorbed jaws. If you domain all these techniques, and there are a bunch of them that you can understand and domain, you can do tricky cases and make them stable over time. That's one main topic over my full arch courses is around this how to handle these resorbed jaws, because there are so many techniques that you have in your hand. They are very powerful. And I'm quite sure, Olga, you will agree with me that if 9 years ago, when we start sharing this case, almost 10 years, that most of the people that we show this to were not sure that a decade down the road it will look like this. Yeah, you saw the same rooms that I did 10 years ago. This case, now entering FP1 with the same implants, with the same implant design. So this is a case with 7 years now. This was a 40-year-old patient with periodontal disease, with multiple caries, several granulomas, poor oral hygiene, and poorly motivated. She was really depressed at this moment in time. This is the intraoral situation. This is how she came up to us. And the situation was, first of all, tricky because we need to change her before we start doing anything to this. So this was the image, and it was like you see there, all full with granulomas, caries all around, big radicular caries everywhere. So unfortunately, this was a final dentition. We need to extract these teeth. But back then I told her, okay, but you have, in your case, I would much prefer to do an FP1 on the upper jaw than to cut all that bone away, because you're very young. Your tissue, yes, it's not healthy, but we can make it healthy before the surgery, and we did perio treatment before. And we can work around to try to create a smile that's leveled and that's beautiful, that's natural. So we'll try to make an FP1. Back in that period in time, with no technology, this is more than 7 years ago, what we did is that I took some impressions, I used the casts, and I started to placing teeth by teeth in the right zenith position that I wanted. And then I created some sort of Gallucci guide that you can always go back to the place and make sure that you are working on the right level, so that you control better where the position of your implant is, the depth of your implant is, where your multi-unit would settle, what angulation of the multi-unit for each position. So this would allow me to always have an understanding of 3D positioning of all the components, so that I would not mess up with my FP1. And I would always duplicate these in a transparent way. So during the surgery, if I wanted to test something, I could always go with that transparent thing in and make sure that I get all the measurements in my head right. Okay. So there was no combination between worlds. So I had a CT scan where I had my planning, and I had to make the matching in my head to what was the actual situation. So this would help me to have a better understanding if I was right in the positioning, in the depth, in the selection of the multi-units, so that I could capture these prosthetics in the end with that guide that I showed you, and make something beautiful out of it. So this is after the capture and immediately placed. On the lower jaw, we end up with an FP3. We cut that bone away. It was way too contaminated to be able to do something else. We cut it, we cleaned everything, and we did a standard all in full. After 3 months, this was the situation. You can still see tissue healing from the bone regeneration that we did, but everything was looking good. All the papilla were in place, the volume was maintained, everything was looking nice. So back then we would again make we make an impression with silicone and create afterwards with all the analog workflow that you all know for many years, create an FP1. And the results were quite good. We were able, nevertheless, to get great and stable results. You can see the 4 years follow-up. Lower jaw was looking good. Upper jaw was looking amazing. 6 years down the road, you could see tissue looking healthy, looking beautiful. And one thing that we noticed is that from the initial situation to the 4 months to the 7 years, you can see the evolving of the patient as well. You can see the difference in between cleaning a teeth to cleaning a provisional. Still a lot of work to do, still a lot of communication to be done with this patient. And look how improved the tissue look after 7 years, because she learned how to clean properly. We changed her. So we don't change only the set of teeth, we change actually the patient. She's way happier now. She's no longer depressed. She can smile, she can eat properly. And so after 7 years, this is the images, and everything is looking pretty stable. But the main message here is that this was tricky to get. So to get to these results, to make this everything level, to get to this papilla in shape, to select every length, 3D positioning, multi-unit abutment, make it in the right depth, make it in the right positioning, the limitations in between angulations, all of this was tough. And the multi-units, you need to remember, they're 4.8 in the platform, meaning that we would always avoid lateral incisor positioning, because 4.8 in a lateral incisor often compresses the papilla, so you're fighting against the papilla with your abutment, and you end up losing one of the papilla, normally the distal one. So we would try the central incisors, and then canines or premolars, and then forward, because you have more space to work around. So there was a lot of limitations. But then this came along, the matrix. And as I told you in the beginning, I was from the beginning on part of this matrix. I remember the first talk we ever had, me, Olga, and Sandro, around this concept. And immediately I got stuck on the idea. I was already working with what was called true zirconia restorations. I was already aware of the benefits of the zirconia when in contact with the tissue. And always in my mind, I was fighting for space, meaning you want to augment the portion of polished zirconia that goes inside your tissue, because you want to create that adherence zone. You want that esmedemesomic connection in between the zirconia and the tissues. But on the other hand, you're using a tie base, and that tie bases puts a cementation line deep down if you want to maximize the exposure to zirconia, or shallow if you want to make the cement away from the bone. So this equation always was one thing against the other, and this was the first time I saw a solution for that problem, because now with the matrix you can easily control your implant depth. That concave emergence polished neck is 1.8, meaning that you can lower or up that according to the tissue height. You have an absolute freedom on designing the correct emergence profile from there on, so there's no more limitations anymore, and there's no cement anymore, okay? And that was particularly important for me, being in an FP1 or in all that small bridgings and individual restorations that we always do in our office. So the elimination of the middle guy, the abutment, the connection in between the old world and this new world, and with that eliminating the cement and all the malefices that come with it, was immediately an idea that got stuck in my head. So from the beginning on, I wanted to be a part of this journey and to go with this. So like Holger already told you, with a matrix, you can have up to 50 degrees in angulation between the implants, and still you are able to restore them. And then the screw sandwich itself, you can have up to 30-degree angulation in any direction you want. So you eliminate components, and therefore you have more space to work with your tissues and not be fighting all the time against them, because you have to use that middle guide that are the multi-units or whatever abutment you are using. And I want to highlight this the best I can. When you're dealing with a static zone and when you're dealing with FP1 reconstruction in full arch, that's very, very important. You are always considering space. You always want space. You want slim profiles to accommodate for the tissue and to create beautiful papilla, and you don't want to be fighting it all the time. So this was the first full arch case I've done with the matrix. And the first thing I took advantage of immediately was, as this is a digital implant, even though this case is turning 6 now, and even though,
well, excuse me,
yes,
we only see a black screen right now.
well, I don't know why. I'll go out and go back in
Again,
again.
the technical issues. I'm so sorry for this. Maybe you can get out your
Do you
presentation.
see it now?
No, it's still a black screen.
I'll stop sharing and go back in. I don't know why. Here it's working.
Okay.
Okay, I stop sharing and I'll go share again.
Please share again. Now I see you. 1 second. That's the mute thing. So please add your
I'm
mute.
on mute now. I'm on
Yeah,
mute
you're
now,
back.
and
Now I think you can go back into Odette, this case.
is it okay? Is it working now?
Yes, we can see it.
Cool. I'm sorry for this. I have no idea why it's happening.
That's
The trials were fine. I don't know. I have no idea. You're listening to me fine, right, Olgi?
perfect. Yes, everything good.
Okay. So this was the first case I did with Matrix, like I was saying, and I wanted to take some advantage of these digital capabilities of this implant, but still the technology was not as evolved as it is now. This case, like I told you, is turning 6 in a few months. So this was the initial situation. This lady was 71 at the time. She lost all her teeth due to periodontitis, so she says, and she had a heart disease. So the first thing I assessed is that I didn't like this denture she was wearing. She was way too bulky, occupying way too much volume. The lip was not looking natural to me, and I didn't like it. So, but this is a tool that we have. I know I didn't like it, and I tried to understand if I didn't have any bulk on the lip, if it would look better on her. And immediately I realized that the lip looks better without nothing than with the flange of the prosthetics. So I'm not too concerned with lip support. I just need a little bit, but not too much. So what I did next is that I picked up the provisional and I took a CT scan with those red dots you see there. Those red dots are the DVO that patient has right now with the provisionals, and the red dots are on the next to the tissue on the provisionals. That helps me to understand that how much I want to shrink the DVO and how much I want to make the teeth inner so they don't look that bulky. So all my planning comes from the combination of this CT scan and with the implants in place, with my programming of the implant positioning. And with this combination of these two images, you can make the adaptations without being calling the patient all the time. So I did a new set of DVO. I shrank the positioning of all these teeth so that the lip would come at in a more natural positioning. And I did this all on the software as you see here. Not only that, but I also planned on doing the upper jaw flapless surgery because I didn't need to augment anything. And I was planning for 6 implants with a slight palatal approach. And in the lower jaw, I needed to cut a little bit of bone to create a better platform and to position five implants. So stackable guides. As you see here, this is only tissue. And then with 4 positioning pins and 6 implants on the upper jaw. on that positioning. The prosthetics were pre-prepared. They were milled in PMMA, and they were sent to me with stackable guides, a positioner, so that I would capture them in the end of the surgery. So as you can see, this was like middle ground in between what we used to do and now using advantage of some technology to get to the result in a faster and more predictable way. So this was pilot guided surgery. You can see there the guide for the pilot guide, and you can see here a guide for the punches. And we would place the implants. Back then, this was the only abutment TRI was selling us because of in that time, the difficulties in technology. So I would use them to capture my denture, the provisional denture. And it was in a draw system. I don't use this system anymore. There are better systems now, but back in the days, I was using this draw system. So it would go inside the draw, the restoration. I would, with the pins, go with everything in place. And then I would retain each abutment and stick it with acrylic to the provisional restoration. This was very fast and easy to do. And this was a mix in between analog procedures and digital procedures. So in the lower jaw, again, 3 fixation pins and a guide to the bone cutting to create that beautiful shelf there, as you see in the next images, and then a telescopic site so that I could place the next guides for the pilot drilling. This was very, very fast procedure to do, and then you would place your implants with absolute accuracy. And then again, the draw system, you place the restoration in place and you pick that up with the provisional abutments. By doing so, in the day of the surgery, this was the situation of the patient immediately after the surgery, still numb, but very happy, as you can see. And this is after 4 months. On the 4 months post-op, this is the X-ray when we were finally removing the provisional restoration. This was how the provisional restoration was looking on her. She was very pleased, and you can immediately see that what we've done in the software with those DCOMs, we were able to perfectly understand where the set of teeth could be placed, and all that information comes from the provisionals. And that's something very important for me, that you understand that often, if you have some information with the provisionals of your patient, use that information and change it. And you can do that easily on software nowadays. So here is a cool example of how I did it back then. And today is even easier, as you get to see in the next cases. And this was the situation. The patient was very pleased. There was very little to be changed. And so I tried intraoral scanners. Back then I was already using intraoral scanners, and I tried. Upper jaw was a match, lower jaw, no match. So this was something that we were still struggling back then. This is 2020, beginning of 2020, I think. And we were struggling. We were still it was still a hit and miss with intraoral scanners. If you have close enough references, yes, the scanners would still make kind of good alignments and you could get passive results. But in lower jaw, fewer references, it was still not working well. And this was one of these cases. So I took an intraoral scanner, actually take some casts as well, and I matched to see the results. Upper jaw was a match, lower jaw it wasn't. So I needed to create cast, as you see here, to be able to produce the 2 zirconia monolithic reconstructions with cutback that you see here. This is the final monolithic reconstructions in place 4 years after the surgery, 4 months after the surgery. And this is the intraoral situation. And here you see the 1-year follow-up, everything looking amazing. This was the patient, very happy with the results 1 year after. She's a very lovable patient, this one. And this is after 5 years. And after 5 years, you can see that the restorations look pristine. They were never taken out. I took them out once in the beginning, 6 months after I placed them. And the first thing I realized is that as we are maximizing this exposure of zirconia that we keep talking about, there was so connects such a great connection in between tissue and the reconstructions that I need to rupture everything after I took all the screws, and it bled like crazy. And I realized, okay, this is a paradigm shift. I don't need to remove these reconstructions because tissue is actually it's like a bulletproof around these connections that we create fully in zirconia directly to the implant. And as it is very high torque screws, 35 newtons, like Holger said, there's no unscrewing. They stay screwed. And over 5 years, once in a while, I go and I check the torque of each screw, and they keep torque. So everything is working fine after 5 years. And look at the lower jaw situation. And this is something I would like to highlight. This is only possible, what you see here, where the tissue is so strong, because it is very well attached to this zirconia. It has to do with the maximization of this exposure of this polished zirconia to the tissues. And this is something that you see when we always try to maximize the exposure of zirconia. This is something pretty common. We see this over and over and over and over again. So for full arch, this was the first time that I realized that we are seeing a paradigm shift with these reconstructions. We're no longer using very short screws with very low torque that need to be checked once in a while, and the multi-units itself need to be checked because you can only screw them with low torques as well. This is a completely different approach. And this was the first time that I realized that this maximization of all this polished zirconia has a tremendous impact in full arch reconstructions when you eliminate the need of an abutment. And this is the 5-year follow-up X-ray, looking absolutely beautiful. And again, this was a case with this combination of techniques between analog and digital. Now, this is a fresher case. This is a 2-year-old case. This patient was sent back to me from the periodontologist because she after many years, she done a bunch of fruit cleaning surgeries. She tried everything, the periodontologist, and up to a point, he said, okay, it's not a point anymore. The patient is having trouble biting. She has a cross bite. Ortho is not an option because of the bone loss. She can no longer bite an apple. She's 70. She smokes 2 packs a day, and she's not willing to quit. There are caries starting all over these roots that are exposure. I cannot continue this anymore. The patient is enough, so she wants to go for implants. And I received her, and you can see the teeth were like this. And I received her, and I said, okay, but I want to do 2 FP1s to you, because even though I understand what you are telling me, I don't want to cut all this bone away. I want to use everything that I can. So I want to save all this architecture and just change what needs to be changed. So I will do implants on you. I understand the argument, but I want to do FP1s. And she agreed. And so I said, okay, so we need to start immediately thinking digitally. And the first communication, it's easy because with pictures, you can immediately start showing to the patient a preview of what you want to achieve. And then with the combination of the DCOMs and the STL files from the intraoral scanner and the CT machine, you can make your surgical planning, but also your prosthetical planning. So we already have a design of the prosthetics we want to achieve, and we have the implants in place. Now, the thing is, even with full guided surgery, quite often you have small deviations. So if we milled or print this restoration in advance, more likely than not, it would not fit in the end. For that, TRI also offers a new approach, a new solution. But as I have the machinery in-house, I said, okay, so let's make all this plan. Let's figure out where we're going to place each implant, the right depth, everything. We create guides to do so, and we have already the design of the provisional restoration. We have everything, but we don't print or mill nothing yet. So This was my design for the guides. So they were, as there were a lot of teeth, we could fix them on teeth and pins. So it's a double fixation, and we went full guided in this surgery. So I extract the teeth I need to extract, kept the other ones. I placed the implants fully guided, as you see there. And then I did an intraoral scanner in the end. Back then, we already had a solution to the problem of intraoral scanners. And the idea was that if you create something that connects the points that the scanner knows as references, being the teeth or oh, sorry, I missed the word. To make the impression, the impression posts for the scanner. In between one thing and the other, if you have this, what we call scan bridge, these things that you see there secured with composite, the scanner would never lose itself. So we get a precise scanning. And this is the idea behind it. So TRI created these things that you would attach to your posts, and with little points of composite security in place, and the scanner would make the reading without losing himself, even in longer distances. That was the idea. And by creating this, we were already seeing that we are more often than not creating a passive fit, around 99.7%. So we were already secure in that moment in time. This is technology that I don't use anymore, and I'll show you why, but it was quite helpful back then because there was no other ways of trying to do this except very expensive photogrammetry. That didn't eliminate the needs for intraoral scanning nevertheless, so it was an added step. And here, in the end, as the technician received the files, the only part he needed to do, because we had everything, is make the connection between the actual positioning of each implant to the prosthetics that he already had pre-designed. So only that small portion needed to be taken into consideration to compensate for the small deviations of each implant positioning. So this is a very fast process. After we receive the files, after a few minutes, we have them back in our clinic to print in our in-house printers. So that's exactly what I did. I received this and I went to the printing machine and I download the CAD design and I printed. I never print just one. I print always like 2 or 3 sets of each. So if anything happens, you have already more than one set of each of teeth for each jaw. This was also the time that I got in touch with this ONX Tough 2 material that was amazing for this because I could see the difference. I never liked before these PMMA printed materials because you could never polish them well enough. But this one, yes, you could get it to this level of polishing. So it was quite amazing. And I start doing this. I start printing in the end of the surgery. It's a cleaner environment. It's easier to do. The patient is on recovery while you're doing this. And then you come back with the set of teeth that you screw retained. You can see the depth of the implants is very easy to manipulate in these cases, which is an added benefit. And you can see the amount of that very slim portion that comes out to the teeth, that in the final restoration, all of that will be polished zirconia. And that's the secret. And in FP1, that's very, very, very important. I cannot highlight this more than that. It's highly important. So this is the immediate post-op, the reconstructions in place. This is the immediate panoramic X-ray. And this is the sequence from what we talked about to the provisional being in place. Still very numb, as you can see there. And after 2 months, this was the situation. Most of it was fine, but we lost an implant on the 6th position. The 36 was lost. It's not difficult to see why. You will see in a minute. This is how the reconstructions came to us. Now, this image, I want to highlight 2 things. One, she didn't stop smoking, so she kept smoking 2 packs a day, as you can clearly see. But if you look closely, look from where the tissue is down, how clean it looks, how pristine it looks. So this means that the tissue was really well attached to this PMMA. And that for me was the time that I realized, okay, now this is safe to use. I didn't like PMMAs till now. I'm meaning printed PMMAs, not milled, but this one is actually good. This material is good. So the tissue was very attached. But I lost at 36 and I had to make a decision. So what I did is this. Immediately in this day, a small amount of anesthesia, I remove the 36, I place a new implant on the 35. And I immediately take an intraoral scanner with that new implant. And I ask for the final reconstructions in zirconia immediately. Because everything was looking so good that I didn't want to wait for a longer period of healing time. It was looking like this, the tissue look. It was so good looking. Papilla was great, the volume was great, the implants looked amazing, the bones situation was awesome. So why wait? Okay, we lost one implant, we can easily change that in 10 minutes time and we can go for the final restoration. So that's exactly what I did. Lower jaw situation was like this, and this is something you're seeing here on reverse. So this is before me detaching. You can see I removed the screw, but now the restoration, look, it's stuck. See? It's stuck there with no screws. See? So that's what I did. I placed an implant on the 35 and I immediately ordered the final reconstructions that you see here. This is placement date. It was just placed. And this is the X-ray. You can see the implant changed from the 36 to the 35 there on the X-ray. All the other ones looking amazing. And this is 8 weeks after. She continued to smoke, as you can see there. That will never change. But this was the tissue situation on this FP1. Quite amazing, right? This is the situation after 8 weeks. The patient was very, very happy with the results. This is the 1 year follow-up of this same case. And this is the 2 year follow-up. And look at the bone situation. Again, very, very stable. And the patient very, very happy with the result. So now you get to see an evolution of this. So when I started with TRI, we had this performance line with the Octa implant, which is a traditional tissue level implant, and the vent system, a traditional bone level implant. And now we have the Matrix. We have the Matrix 1, that's the implant you are seeing to this point. And now we have the Export Matrix. And the Export will soon be worldwide available. Still isn't, still in the small market release phase. But it's quite interesting, and I'll finalize with this. So this is, again, a patient that I received for a full arch treatment in the upper jaw and some implants on the lower jaw. And I looked at her and I said, okay, we need to do an FP1 on you. You have all the characteristics that are suitable for an FP1 approach. So that's what I'm willing to do to you. So I had a little discussion with her. And this communication now with technology is way easier to do with your patients. Because when you make this combination between the STL files and the DCOMs, you can actually show your patient what your plan is, what your goal is, what type of implants you're going to use, what's the smile expectations in the end, what type of prosthetics you're doing. And you can do all of this via software. So that's quite interesting. Often I ask for a mixing between the picture, the front picture of the patients with the new set of teeth that are planning. You can also do that. So this communication will help you to make your patient understand and value more your work. Okay. So I created all this. We created the pilot guide. This was pilot guided. For this system, you still don't have the capability to go full guided. So I use a pilot guide, which often is a system that I prefer. And this is another topic for another day, but I more often than not prefer pilot guided because I still think there's value on feeling your bone and understanding if your anchorage is correct. And when you go in full guided and you don't remove ever the guides, you lost some of the feeling. And some implants of the bone and the tissue, I want to fill them. And with pilot guided, you have this beautiful combination in where you are being precise with the positioning, you are being precise in your entry points and your distribution and your angulation, but still you are retaining the feeling and the control of the depth and some other aspects that I prefer to have control still, despite software. And here is the provisional, milled in the end, printed in the end, like you just saw. This is after healing period. Normally they stained a little bit, these ones, as you can see here, the color is no longer great, but the tissue is looking amazing. You can see the depth of the implants is looking quite nice. The pillar are in place. So next step, now I use this. This is from Shining. TRI provided us with these adapters you see on the left. So these adapters go inside the connection of your matrix implant, and they allow you to connect these flags from the Shining technology. So this is a system that combines the photogrammetry with the scanning. And it's very easy to do, very precise. And honestly, I don't think I ever made a wrong impression anymore. So this is very, very, very accurate. These flags are really easy to read. And with these adapters with TRI, they work absolutely amazing. So this is the system you see here. And you can see that it retains all the information you need. So the DVO of your provisional is retained, and you can change it if needed. You have the information on the tissue after filling as well. You have the information of the positioning and angulation of your implants. You have you can even record dynamic bites. So you have everything in one appointment, all the measurements you need for your patient, and the rest you can change via software. So this is a very helpful tool that I've been using for more than a year now, and I cannot recommend it more because it's quite amazing. So we went from one situation to placement day, just one appointment, that's it. And we went for zirconia crowns, individual zirconia crowns in the lower jaw, and an FP1 in the upper jaw. This is placement day, so a lot of room to improve still. There's a lot of information going to the tissue now. This is the X-ray of placement day, and you can see how passive fit it all looks. So it's quite precise to use this Shining technology that I just showed you. And this is the situation of the patient in the end. Very easy surgery, very relaxed environment, everything since the communication to the end result done with the help of software, and that maximizes your results. And it maximizes your approach with the patient. The patient is fully engaged from the beginning on. So some considerations about FP1 that I think that are interesting, and that goes along where I was making the point with this matrix journey that we are. You knew from the beginning on that 3D implant positioning in FP1 is mandatory. You need to be able to create, to make a very precise 3D positioning of your implant. So you need to center your implants. You don't want to be leaning on one side or the other because you will be fighting papilla. And your abutments should never invade that papilla zone. That's why I told you that we would always avoid lateral incisor positioning, because that 4.8 platform is often too wide and compresses the papilla. And you should have deeper implants because you needed space to place an abutment, and then comes the tie bases or the metal frame for your zirconia reconstruction. So you need to deep down your implants, and you need space for those multi-units. So all of this space is no longer necessary. And you need to use slim abutments, because straight abutments, because you want to support the tissue and have space for it and not fight it and make it go away. So now, none of this matters when you're using a matrix, because you can design freely what you want. You can maximize the exposure of zirconia. You only have one gap, not two. You have all these benefits, and the communication digitally, the digital chain is way easier. So all of these are benefits. Still, to this moment, there are some analog advantages. And that's why I often prefer pilot guided than full guided surgery. because the freedom on the surgical procedure, the freedom of mind, adapt to the situation is often needed. And if you're working in a very strict environment that doesn't allow you to take off the guides and do something, if you're stuck to that A plan and something goes wrong, you may be in trouble. You have better control of torque because you feel the inputs. If you're aiming for the piriform ring, that golden triangle I showed you in the beginning, you feel it when you get there. But if you are going fully guided and you are slightly offset, you will not feel because you have a lot of friction of the guides and you don't feel the bone as well. So for really resolved jaws, I still prefer to go freehand and understand the anatomy and the anchorage points. It's easier to control the implant depth because you realize you make better assessment of the length of your implant, but it will also implies that you have a higher length stock in your office, but you should. And it's faster on open surgeries. A well-trained surgeon is way faster without guides doing an open surgeon than with guides. And like I said, for me still, in very soft jaws, this is the way to go. You need to understand the anatomy, the anchorage points, and go. But there are more and more digital advantages. The first one, and highly important, our predictability. We are more precise in our approach, leading to more stable results over time. The main one, storage the information in layers. You never lose information. You always work with the basis of the information you got from the first intraoral scan and the first CT scan. That combination allows you to work on layers. It makes your work so much easier. It's faster in closed and minimally invasive surgeries. In FP1, it's way faster than what I showed you in the beginning. That was very, very tough. You can better preview the outcomes, and that leads to a better patient communication as well. And you can print after the surgery, which makes it a much cleaner environment, a much cleaner surgery. Your patient can rest and have that moments for her after the surgery while you're printing. It doesn't take all that long, and the surgery becomes a much better experience for your patient. And you don't print just one, you print 2 or 3 sets. And if something happens, you have that sets there ready for your patient. Exactly one looking like the other. And this is it, Holly. This was
Yes.
my topic for today. I will stop sharing my screen now.
Stop sharing your screen. Thank you very
Yes.
much, Joel. I'm not sure if I should start sharing my screen again because we really we were very sorry to have these technical problems at the beginning. But again, thank you, Joel, for this nice presentation through the whole journey from analog going into digital. And then also from using abutments in full arch treatments, it's always necessary to use abutments in any other implant system, and then to have these possibilities to go abutment free, especially for FP1 treatments. I think this is really the future. This is where the way to go for especially full arch treatments. Out of all
Agree.
since you were explaining. There's certain questions, and we are already like 5 minutes due to our technical problems over time. But anyways, I use the chance because I see here really people following from Colombia here. For example, there's one question to the treatments. What type of tools do you use to which device you use for cleaning and maintains the FP3 structures, like cleaning them. Just maybe quick
Okay,
answer.
so yes, the FP3 always I remove them every 6 months. I test all the multi-units torque again, not to create some unscrewing of the multi-units. I clean the prosthetics in my clinic. I clean all the screws as well. I test them. When they're getting loose, I change them and I'll go back in
Okay,
every
then
6 months.
yeah. Which software are you using in prosthetic design? This is, I mean,
Oh,
maybe a question where I can answer. I mean, there's several ways possible, and in this moment, this is still the main software to use for prosthetics design is more or less ExoCAD or TreeShape.
Exocad.
Yeah, and in this case, we work with different laboratories and different designers. Thank you to our dental technicians here to create the designs, but also you know that we at TRI we are working in single crowns already with AI. So we have created an AI crown design software, which makes it possible for single crowns in this moment up to 3 unit bridges to let design the prosthetics by AI. And that's actually the next question here. Do you believe that we can do designing fully on artificial intelligence in the future? Do you believe?
Yeah, pretty soon. Not in a very far away future. I believe in a very. I tell you something. I just changed my software in the clinic, and this new one is AI based, and it's amazing what it does for you. It's quite amazing. You analyze the CT scan, you select the position of your implants. He immediately asks you if you want guides. He can produce the guides for you. You can just send it to the printer and produce. It's amazing what's happening right now. But the power computing needed for this is still an issue. So often it demands too much on the computers, and they will go down, and I will need to reset them. But it's we are very close to that moment in time where it will be much easier for us to create all of this before the surgery. Way easier. It will all be AI based. I'm sure of it.
There's always maybe the mismatch between the hand and the theory. So if you have a design by a planned and having the real position of the implants, there's always a little mismatch. There's also
Mhm.
answers to this, which TRI developed with our teeth to go. That means really that we
Yeah.
can compensate those mismatches. This is also a topic we will have in the next webinars with Stavros Pelikanos. He will talk about these treatment ways. And since
Exactly.
I'm looking forward to much more to come with you. Thank you very much, Joel. And everybody have a nice day, evening, or morning. Thank you and
Depending on the position of the world. Bye bye to you all. Thank you so
bye, bye,
much.
bye, bye.